Hypokalemia is defined as a serum potassium less than 3.5 millimoles per litre. Under most circumstances, more potassium is ingested than is required, so serum potassium concentrations are largely regulated by controlling the amount of potassium lost in the urine. Potassium is freely filtered by the kidney, so as much as 90% of this must be reabsorbed by the time the ultrafiltrate reaches the distal tubule. It is the regulation of the loss or retention of the remaining 10% that ultimately controls potassium levels. In hypokalemia, potassium is reabsorbed from the distal tubular fluid. Total daily urine losses should be less than 30 millimoles per day if the kidneys are functioning normally. Suppression of aldosterone production limits the loss of potassium from the principal cells, while active reabsorption of potassium occurs at intercalated acid-secreting cells. Enhancement of this process leads to a relative aciduria and is dependent on normal magnesium levels. Common causes of hypokalemia include reduced intake, increased loss from the gut or kidney, and movement of potassium from the extracellular to intracellular space. Importantly, potassium reabsorption in the kidney is usually inhibited by concomitant hypomagnesemia and will be refractory without magnesium replacement. It is rare for decreased uptake alone to cause persistent hypokalemia, though in concert with other factors, it may be a contributor. Elevation of the serum pH leads to an exchange of intracellular hydrogen ions for extracellular potassium ions, resulting in hypokalemia. As a general rule, potassium falls by 0.5 millimoles per litre for every 0.1 increase in the serum pH. Alkalosis also causes loss of potassium because of the excretion of excess bicarbonate in the kidney, which combines with potassium and results in additional loss. In certain circumstances, rapid cell growth or activation, such as in hematological malignancies or after blood transfusion, potassium can be rapidly taken up, leading to hypokalemia. This may also cause a factitious hypokalemia in blood samples taken from patients with leukemia, as the potassium may be taken up by the cells after the sample is drawn. Hypothermia is also known to reduce serum potassium due to a transcellular shift, and the reverse applies as the patient rewarms. A number of drugs are associated with hypokalemia. Insulin directly stimulates the sodium-potassium ATPase pump, leading to transportation of potassium into the cells. This powerful effect is commonly seen when patients presenting in diabetic ketoacidosis are initiated on insulin. In some cases, administration of carbohydrates may cause hypokalemia by stimulating insulin release, something seen in the uncommon condition of refeeding syndrome. Beta agonists may also stimulate the pump, but may also act by increasing the response to insulin. This effect can also be seen in patients with intense endogenous sympathetic responses. This response is mediated by the beta-2 receptor and is inhibited by non-selective beta blockers such as propranolol. Chloroquine, used in malaria, is another potential cause. Rapid expansion of the malarial parasites can also contribute to this situation. Aldosterone increases the secretion of potassium at all endothelial surfaces, but particularly at the renal tubule and the gut. A number of causes of excessive aldosterone effect, such as corticosteroid therapy, malignant hypertension, and Conn syndrome, may be associated with hypokalemia. Substances that resemble aldosterone, such as licorice extract, may also be implicated. the rare familial disorder known as familial periodic paralysis, which features acute episodes of weakness and respiratory failure associated with hypokalemia, is sometimes precipitated by exercise, stress, and carbohydrate loads. It is more often seen in Asian males and may be associated with thyroid disease. Gastrointestinal losses of potassium can occur with large fluid losses of any kind. The concentration of gastric juices is relatively low, however, and the hypokalemia associated with gastric outlet obstruction is more related to the urinary loss of potassium precipitated by the associated alkalosis. Potassium can also be lost in great quantities via the urine. The rate of flow of urine to the distal tubule directly increases potassium loss by maintaining a high concentration gradient down which the potassium moves into the tubule. When the cause of the diuresis is diuretics, the effect can be amplified by the consequent increase in aldosterone associated with volume depletion. Diuretics, in general, increase sodium delivery to the distal tubule, which is exchanged for potassium, and when diuretics result in reduced circulatory volume, the production of aldosterone enhances sodium resorption at the expense of potassium. Both of these effects result in additional potassium wasting. Patients who are on renal replacement therapies in the ICU may also lose lots of potassium, which can be limited by careful prescription of the therapy. In some circumstances, replacement is also required. Uncommonly, potassium is lost in significant quantities via the skin, such as in profuse sweating and burns. This loss is exacerbated by the increased aldosterone release associated with volume deficiency. The most common features of hypokalemia are cardiovascular abnormalities such as atrial fibrillation and ventricular tachyarrhythmias, weakness and flaccid paralysis, respiratory failure, ileus and constipation, and diabetes insipidus. In severe cases, rhabdomyolysis may also occur. The ECG features associated with hypokalemia are quite characteristic. Initial changes include PR interval prolongation and widening of the QRS, followed by T-wave inversion and the development of U-waves. By the time hypokalemia is worthy of treatment, there is often significant total body depletion of potassium, and large amounts in the range of 200 to 400 milliequivalents are often required. Factors that mediate redistribution of potassium should be borne in mind, however, as this can mask the true potassium loss. A good example of this is diabetic ketoacidosis, where the acidosis, renal hypoperfusion, and insulin deficiency promote redistribution of potassium into the extracellular space. The serum potassium level may therefore be normal or even high, despite massive depletion of total body potassium. Resolution of these factors with therapy for DKA may lead to a calamitous drop in serum potassium. As discussed previously, hypokalemia may be refractory in the presence of hypomagnesemia, and this should be corrected early if present. Potassium can be administered either orally or intravenously. Oral potassium is well absorbed and is a reasonable way of replacing potassium gradually. Doses are comparable to IV forms due to the excellent bioavailability. IV potassium is commonly used in unstable patients and where the oral route is unavailable. Oral preparations are available in standard and slow-release preparations and can contain combinations of potassium chloride, potassium bicarbonate, and other potassium salts. Doses range between 5 and 20 millimoles per tablet. Care should be taken using the oral route in patients with poor enteral absorption, particularly for slow-release preparations, as potassium may accumulate in the gut and then be rapidly released as the gut function improves. Mild to moderate degrees of hypokalemia can be treated with between 40 and 80 milliequivalents per day. Intravenous potassium comes in a variety of concentrations. Concentrated solutions such as 10 millimoles in 10 mils of fluid are available and should be diluted before administration. These neat preparations are less commonly available now for safety reasons. Intravenous potassium should initially be prepared in crystalloid solution rather than in dextrose, as the high carbohydrate load can contribute to hypokalemia. Pre-mixed bags of diluted potassium are also available. Concentrations higher than 40 millimoles per litre delivered via a peripheral vein can cause pain and thrombophlebitis. Intravenous potassium should not exceed a rate of greater than 40 millimoles per hour, and plasma levels should be frequently monitored. Rates greater than 10 millimoles per hour should only be given with cardiac monitoring available. Care should be taken when administering potassium rapidly into the central circulation because of the potential for cardiac conduction abnormalities if a concentrated bolus of potassium reaches the heart without appropriate dilution in the blood. Once emergent problems have been resolved, a more gentle replacement plan can be employed. In some conditions where renal potassium wasting is the cause and is ongoing, potassium-sparing agents may be used. Amiloride, triamterene, and spironolactone are examples. The combination of potassium replacement and these drugs should only be used with close monitoring of potassium levels. In patients with cardiac instability or related arrhythmias, a target level of 4.0 to 4.5 millimoles per litre is usually aimed for. In rare circumstances where hypokalemia is due to renal tubular acidosis, potassium acetate or citrate can be given, as the chloride form may